So hello and welcome to episode 3 of the surgical discussion series with Johnny and Ed. This is going to be on the stomach. My name's Ed.
And my name's Johnny.
During this podcast, we're going to talk about the important anatomy of the stomach. We're then going to consider 2 very important upper GI emergencies. These are the upper GI bleed and perforation. And then lastly, gastric cancer. Good. Pretty excited?
Yeah.
Let's get on with it then.
Okay, the anatomy of the stomach. It's a J-shaped organ with 2 curvatures, the greater on the lateral side and the lesser on the medial side.
Mm-hmm.
The parts are the cardia.
That's where the esophagus
enters.
Yeah.
The fundus.
That's the bit kind of rises above the level of where the esophagus enters.
Yep, the body, the main part.
Yep.
And the pyloric antrum near the pyloric sphincter,
which is the outflow. Okay?
Okay, the blood supply.
It's quite complicated, the blood supply.
Yep, the arterial supply comes from the left gastric artery, which is a branch of
celiac,
and the right gastric, which is a branch of
the right hepatic.
Okay, and these supply the lesser curvature.
Yeah. And the greater curvature is supplied by the left gastroepiploic and the right gastroepiploic. The right gastroepiploic is a branch of the gastroduodenal, and the left gastroepiploic is a branch of the splenic, which is another artery that comes off the
celiac axis.
Yeah.
Okay. Venous system, it enters the portal system of the liver, and the lymphatics are the local, which is perigastric, and then celiac, which we'll talk about later, and then into the thoracic duct, which drains up and then drains into the left subclavian.
Yeah. And also that's important because of Virchow, his node. Left supraclavicular node is a Virchow's node. Okay. So we're now going to talk about 2 important upper GI emergencies. For more information on other GI emergencies and the specific management of hypovolemia and shock and things like that, there are some podcasts available in the emergency section of the site.
They're great.
I thought I'd put in a little plug there.
Mm-hmm.
Acute upper GI bleeds. The best way to think about these are that they can be split up into ones due to ulceration, ones due to inflammation, and then other ones. So the ulcerative ones are duodenal and gastric. Duodenal ulcers are the most common cause of an acute upper GI bleed, making up about 40%. With inflammation, you can have gastritis and esophagitis, both causing bleeding, and otherwise you can have Mallory Weiss tear, carcinoma, and varices. What's Mallory Weiss tear?
That's tear often associated with forceful vomiting. Especially after alcohol.
Yeah, and it's a minor tear. If it was a full tear, we'd call it the Boerhaave syndrome.
Indeed. We mentioned earlier.
In episode 2, I believe. Yeah. Carcinoma can cause it, particularly ulcerating gastric carcinomas, but we're going to talk about that later. And obviously varies in association with portosystemic hypertension. Yep. Okay, clinical features. Broadly, we can divide up the clinical features into those that are due to the fact that the blood's been displaced from the vessels, and those due to the fact that you've lost blood from the vessel. So the fact that it's been displaced can cause either a melena, where the blood is digested, passes through the GI tract, and results in black, tarry stools that are usually quite offensive.
Mm-hmm. Melena is also a classification of whale.
Is it?
Yeah, look it up.
Okay, or the blood can be vomited up, in which case it's typically described as coffee ground vomit. Obviously, if you're losing blood out of the vessels, this is not a good thing, and there may be signs of hypovolemia, stroke, shock. But we're not going to talk particularly about that. Yeah. Okay, so management of these patients. There's kind of a few phrases that it's useful to say when you're asked about this in a PACER situation. You would say, I would make sure the patient is in a safe place, attach the monitoring equipment, and I would inform a senior colleague. You then want to resuscitate the patient with respect to his airway, his or her airway, breathing, and circulation. In terms of the airway, you would secure the airway. In terms of the breathing, you would probably give oxygen. And in terms of the circulation, you would do many things. you'd obviously want to get in 2 large bore IV cannulae,
Grey or brown.
grey or brown. You want to take standard bloods. Important things to remember with the bloods, in addition to, say, your FBCs, U's and E's, LFTs, are amylase. This is an abdominal condition. And also group and cross-match 4 units of blood, because if they're losing blood, you may want to be giving it back to them. You also want to, of course, as part of circulation, assess the patient's volume status. And as I said, we're not going to go into this here because I think we've covered it quite well in the first podcast on surgical fluids. So go and have a listen to that. But we are going to give you some basic guidelines. There's a huge debate in the literature about whether to use crystalloid, colloid immediately in the case of intravascular hemorrhage. However, it's nearly always safe to give 2 litres normal saline stat. Obviously, in an elderly patient and stuff,
Liver failure.
or in liver failure, you don't want to be doing this. But generally, 2 litres normal saline stat's okay. Then you either want to use a colloid or blood. Well, in fact,
So colloid is blood is a colloid.
Blood is a type of colloid. It's a type of natural colloid. Yeah. Okay. Examples of colloids, things like gelafusin and hemocell, gelatin-based things. Okay, so you've done your ABCs, the patient's safe, you've got senior review, etc. What you want to be doing now is directing the patient towards OGD. But before you do this, you want to think about using things that have been shown to improve survival and prognosis in these patients. Johnny, can you give us some examples?
So proton pump inhibitor, so high dose omeprazole.
Yep.
Antibiotics, you can use cephalosporin, but many others are used.
Yep.
And terlipressin to reduce portal hypertension, so if varices are like.
Yeah, and terlipressin has been shown to reduce morbidity actually by about 30% in varices-related esophageal bleeding.
So helpful. Very
helpful. Yeah. You can also do something called the Rockall scoring system. We thought about putting the detailed system on here, but I don't think it's necessary for us to actually know the system. What it's important to know is that the Rockall scoring system is a prognostic indicator in an upper GI bleed, and it's based around 2 things: the pre-OGD score and an additional set of values given at OGD, and these together make up the final score. Pre-OGD score is composed of things like the age, comorbidities that the patient may have, and the presence or absence of shock. At OGD, the endoscopist will then add extra points according to diagnosis and risk of rebleed. And it's perhaps important to remember 2 values. Less than 3,
It's pretty good.
it's pretty good. Greater than 8,
It's poor.
you're in trouble.
In fact, if the score is between 5 and 11, you have an 11 to 41% chance of death.
How do you remember that?
Numbers. I'm good with numbers.
I can never remember that. Anyway, very impressive. Right. So, as we said, you're directing your patient towards an esophageal gastric duodenoscopy, otherwise known as an OGD. You want to, of course, do this as soon as possible because not only is this a diagnostic investigation, but it can also be therapeutic. And how can it be therapeutic, numbers man?
Well, if you've got varices, these can be banded.
Yeah.
Sclerotherapy.
Mm-hmm.
Injection of adrenaline. And
Yep.
you can coagulate either with a heater probe or bipolar coagulation.
Okay. So, patient's gone for their OGD. They've had the second part of their Rockall scoring system, etc., etc. You can then classify them according to 2 situations. Either they're going to be stable or they're going to be unstable. They're going to be unstable if they continue to have uncontrollable hemorrhage or if the endoscopist has told you that there's a really significant chance of rebleeding. If this is the case, they're unstable, you want to move on to surgical treatment, which we're going to go on to in a second. If they're more stable, you can treat them conservatively. So you can try and figure out why they were bleeding. Say you want to get them to stop their NSAIDs, give them advice about alcohol cessation, and you want to start medical management. You want to start them on a PPI, such as omeprazole or lansoprazole, or you want to try and eradicate Helicobacter pylori.
Can be done in 2 ways.
Yep, 2 regimes.
Either the PMC,
Yep.
using a PPI, metronidazole and clarithromycin,
Mm-hmm.
or PAC, where you substitute amoxicillin for metronidazole.
Okay. So those are the options for the stable patient. You might also, of course, want to follow them up. It's probably important. Yeah. So, as we said, if they're unstable, you're going to go to surgery. There are a couple of options. The most commonly used option, and this is probably because most actual upper GI bleeds are duodenal, about 40% of them, is an underrunning of the ulcer. If there's a gastric ulcer, this can be excised directly from the stomach. And finally, if it's very, very severe, you might need to consider doing a gastrectomy. Right, that's that done.
Yep. Next emergency?
Perforated peptic ulcer.
Okay.
Hit it.
So, obviously, we need to think of who's going to be affected by this. Most commonly, it's males in a 2-to-1 ratio, the elderly, and you've got to think about risk factors. So those affecting lifestyle, whether you intake a lot of alcohol, whether you smoke, and other diseases. So H. pylori and drugs.
So things like
NSAIDs, steroids, things like that.
Stuff like that.
And then there's the rarer causes, so burns causing a curling ulcer, head injury or neurosurgery causing a Cushing ulcer, and the Zollinger-Ellison syndrome. What's that, Ed?
Interesting. It's caused by a gastrin-secreting tumour, usually in the pancreas,
resulting in a higher acidity
and therefore increased likelihood of ulceration and hence perforation.
Okay, so the types. Most common places are the duodenum in the first part anteriorly. As we said, that's 40% of perforations. Also gastric ulcers, and if you've got an ulcerative gastric cancer.
Which we'll talk about later.
So, clinical features. So on the history, they might describe sudden onset of upper abdominal pain, which is localized to the epigastric region, and then becomes generalized. And then they may have signs such as, well, obviously they'll be sick, possibly with hypovolemia due to blood loss or sepsis due to infection.
In the abdomen.
And then they'd have generalized peritonitis.
Now generalized peritonitis is an important, I suppose, almost abdominal syndrome to be able to recognize on examination. So the next slide really just talks through the things to be looking for. And obviously you want to be going through your system. So, inspecting, palpating, percussing, listening for bowel sounds. So what would you find?
Well, they'd be still, unlike in renal stones, but they move around. It'd be a rigid abdomen. And then they'd have generalized tenderness with, obviously, the guarding and the rebound.
And the rebound indicates that there's some level of peritonitis present. So they'd also have absent bowel sounds. Why is that?
Because of a paralytic ileus.
So the bowel almost gets paralyzed by the caustic effect of the blood and the shock of the pus. Okay?
So investigation, as always. Cultures, blood cultures, in case there's sepsis. Bloods, ABG, possibly.
Could be important. If they're very unwell, if they've got sepsis, they could have a lactic acidosis. You want some kind of idea of what's going on with their metabolic and respiratory components there.
The venous blood tests, as we described previously. Imaging. So the main thing is the erect chest radiograph. So you're looking for free air, normally under the right hemidiaphragm.
Can be under both, but right is obviously the more specific one, because on the left, it looks like often there's free air because of the gastric bubble. So air under the next slide shows that actually quite well.
A CT scan to find out where the perforation is. And that's about it for this.
No scopic or functional test really here. Okay, so here's a nice chest X-ray. Actually, this shows air under both hemidiaphragms, but it's marked particularly on the right. And this is something that is easy to actually miss, particularly if it's small. So as part of your chest radiograph interpretation, add to the end, always at the end of it, say, or look for air under the diaphragm. Okay, management. As always, you need to resuscitate the patient, so you go through the standard things, put them in a safe place, monitoring equipment, review. airway, breathing, circulation, focus on all of those things. But generally, management can be divided into conservative management and surgical management. Often patients, if they're very, very ill with a perforation, won't be suitable for surgical management and will just need to be managed conservatively. And in fact, in some patients, the perforation can self-seal, can't it?
Yeah. Your mentum patches it.
Patches the perf. Okay. So as part of this conservative thing, you do the normal kind of stuff. So fluids, analgesia, nil by mouth plus an NG tube. You'd also want to give them antibiotics because, as we said, having a perf significantly increases your risk of intra-abdominal sepsis and septicemia in general. Surgical techniques, the most important one is a laparotomy with washout of the abdomen to get rid of all the blood, gunk, acid, etc., and then to do an omental patch repair of the ulcer. Other alternatives include excision of the ulcer and, if severe enough, a total gastrectomy. Okay,
the last part, gastric carcinomas.
Gastric carcinomas, excellent.
So once again, we start with the epidemiology.
Yep.
This is more common in males and in areas of Asia, such as Japan and China, which may be due to their diet.
Could be. That's an important risk factor.
So risk factors of lifestyle, smoking, alcohol, diet. Common things in the diet are cured meat and fish.
Cured meat and fish, thanks. Other diseases. We put blood group A. I mean, I don't think having blood group A is a disease, but it is a kind of body state. So I like to think of it in that kind of group. Other things, atrophic gastritis, pernicious anemia particularly is associated with gastric carcinoma, and finally Helicobacter pylori infection. Pathology.
So, majority are adenocarcinomas, but you obviously need to think about other things which may be present, so lymphoma or MALT, mucosal associated.
Lymphoid.
Tumours,
yeah. And actually the stomach, in terms of lymphomas, the stomach is a very, very important extranodal site for lymphoma metastases and formation. There's tons of lymph nodes around the stomach. Okay, so classification, we can do this into macroscopic and microscopic. What kind of classification is there on the macroscopic?
It's the Borman.
Borman classification, okay?
So, obviously, fungating, excavating, ulcerating, and Lionitis plastica, which is a leather bottle. It means a leather bottle, Lionitis plastica. And basically it means that the whole stomach has become enveloped in the malignant process, and it's become stiff, non-compliant, and completely involved superficially all the way around. It's interesting.
Okay. So I like to add the historical detail.
That's great.
And microscopically, I should say really, the pathology can be divided into intestinal and diffuse. Intestinal type is about 53% and diffuse about 30%.
Okay, before we get to clinical features, we've got to think about the spread.
Now, the stomach cancers are quite unusual. Well, they're not unusual, but they show all types of spread, don't they?
Direct to organs surrounding.
Such as?
To the colon.
Spleen. Maybe the pancreas.
Lymphatic, as we mentioned before, to the supraclavicular node.
Via Cow's node, no less.
Hematological and transthalamic.
And there's an important eponymous tumour that occurs via transthalamic spread to the ovary.
Krukenberg, is that?
Krukenberg tumour, that's right. Yeah. Anyway, so clinical features. As always, we can split it up into generalised features, such as malaise, weight loss,
anorexia, anemia.
Yeah, okay. Local features, such as an upper abdominal mass. There may be hemorrhage. If you remember earlier, one of the causes of an upper GI hemorrhage and perforation is a gastric carcinoma, and also gastric outflow obstruction. You also want to think about metastatic features. For example, if the liver's involved, there may be some right upper quadrant tenderness and subtle alterations in body state, nausea, vomiting, all that kind of thing. If neurological system or brain is involved, there may be seizures or focal neurology. And if the bones are involved, there may be
bone tenderness.
And evidence of hypercalcemia.
What is PO?
I don't know. I'm having a moment. Never mind. You do investigations. I'm exhausted.
Okay, well, investigations, no cultures to speak of, really. No ABG really necessary. So we're straight on to venous. May show an anemia. Deranged LFTs, if there's
Liver
metastases to the liver.
Yeah.
Derangement of calcium, if there's metastases to bones. And a change in INR due to clotting derangement.
And the INR is an acute thing, and the albumin is a chronic thing. Okay.
Imaging, the first line would be a barium meal, and then staging with a CT. And then there's other imaging for metastases, so whether there's rib involvement, a chest x-ray, a CT of the abdomen for the liver, also an ultrasound for the liver, and a CT of the head.
Yeah, you probably wouldn't dive in and do all these things, but if they were indicated by any of the metastatic symptoms and signs that we spoke about, then you would.
True.
Yeah, it is true.
Okay, and scopic, so gastroscopy.
Yeah.
And a biopsy.
Yeah. Treatment.
My favourite, remember the MDT approach.
Everyone's important.
Macmillan nurses, oncologists, the family, all important.
Yep. And it's important not to be too cynical. You have a habit of doing that.
Yeah, I'm sorry.
Yeah. Anyway, go on.
Okay, so conservative, thinking of pain relief, antiemetics, so metoclopramide.
Nice antiemetic.
And decrease of secretions with hyoscine.
Excellent. And surgical treatments.
This is only if it's an early diagnosis and resection is possible. And then the types of resection you can do involving the lymph node clearance are a D1, which is resection of the tumour, and also the perigastric nodes, and a D2, which is a D1 and the celiac nodes.
Yeah.
In certain circumstances, you might want to take a bit of the pancreas.
Yeah. And the spleen.
And
the spleen can be involved as well. Prognosis isn't great, is it?
No, but not as bad as esophageal.
No, which is it 5%? Yeah. 5 years? Okay, so prognosis is about 10%, 5 years for stomach cancer. So, that basically completes this podcast. We've looked a little bit at the anatomy of the stomach. In particular, we've looked at the rather complex blood supply. We've looked at 2 upper GI emergencies. You should have a basic approach to these, know what to say, have a basic idea about resuscitation, particularly in terms of fluids, and how you proceed to OGD. And we've looked at gastric cancers following our usual approach.
Okay.
So, thanks for listening to this podcast. We'll see you soon. It's goodbye from Ed.
And goodbye from Johnny.
Thanks for listening to this podcast. For others like it and additional supporting materials, please visit our site at podmedics.co.uk. No, the outro is actually already programmed.
Bollocks.
Yeah, we'll put that on the outtakes.
What outtakes?